no different than bone will a couple of mils below it if the cementum is lost there. Dental phobias. The people who hate coming to the dentist are the people who can't breathe through their noses. And so we'd see the cracks. These are things that we see all day long. We would see the endodontic problems and the nerve problems. We'd see the cheek biting. We'd see the mucoceles. We'd see the geographed tongue. Some people correlate that with a manifestation or extension of lichen planus. And I personally think there's a very close correlation between lichen planus and hypoventilation in women. Yeah, your fluoride bombs, don't need to go on about that. Doesn't matter how much fluoride you have when you're a kid. In fact, in some respects, fluoride can be a problem. Invasive cervical resorption is a beauty. Just eats teeth away. So the gum just sees the tooth as a foreign object and away we go. They're all the same teeth. And all of these patients, you mount them up once they stabilise on a split, and invariably these are the teeth that have the high spots. And of course you see your tori, and we get tori because of tensile stress build up in bone. So compressive stress causes bone to go away. That's why you get flabby ridge when you pull out teeth and stick in a denture opposing a natural dentition. But when you expose bone to tensile stress, it will grow, and it will grow very quickly. Extraorally, what were the signs and symptoms that I was correlating with these patients? Well, obviously they had big masseters. They would complain of headaches. They might get TMD. They might complain of visual disturbances. That's an interesting one. The serrated gonial angles, which we pick up on the radiographs. A lot of these people, you know, when you inquire about their sleep and you dig more on that, a lot of them will say, you know what, I have dreams about my teeth. I dream that I'm smashing my teeth to bits. Eagle syndrome. Eagle syndrome's a beauty. All right? And again, where we get calcification of the stylohide process, we're starting to connect that now with chronic tension on structures within the cervical tissues. Mouth breathing. We're awoken with pain, not by pain. That's a key one. Yeah, I woke last night, mate, I've been up with pain. Did you wake with it, or were you woken by it? If you're woken with it, it's usually muscular. And we get the ear problems, which I'm not going to go into too much. That too, I had to give a talk to some audiologists about this a year or two ago, and that's a different world, so I won't go into that. But again, just recognise your serrated gonial angles, the patients with the big stiff masseters, and just understand that where I put my little indelible dot there, there's not a big distance between the TMJ and the ear. In fact, the bone is very, very thin. And so we just need to appreciate that, yes, people can get ear complaints, but there are many causes of ear complaints. And there's direct causation there I don't read too much into. So it all changed in 2007. At that point, then I'll take a couple of questions. You, Alex?
Migraines associated with it as well.
Beg your pardon?
Migraine headache.
Yeah, good. So migraines, again, you've got to look at this on a balanced scale. Lots of different things can cause migraines. But I think it's fair to say that if there is a component of headache associated with muscle tension can contribute to migraine. But we also appreciate that one of the biggest causes of migraine is hypoventilation. And what hypoventilation does is we get cardiovascular compensation in our sleep. And with cardiovascular compensation, the heart trying to work harder because it's not getting the oxygen it wants in deeper planes of sleep, which again I'll come to, then that sets the stage for the migraine. So I'm not a big believer. I would put migraines in a separate category. I would say there's direct causation there. I would say tension headaches, yes, but migraines I think is more connected to the underlying physiology as to why we're mouth breathing. Yep?
And when you use the term hyperventilation, do you actually mean breath holding or...?
I'll come to that. So that's in my next step. All right, we're clear on that? Yep, okay. So in 2007 it all changed. Now, tell me, is this new to a lot of you guys, or are you fairly familiar with some of this stuff? Yes, no? You? You look like you're smart. Yes? Okay. So when did you graduate, just so I know?
2013.
Right, okay. All right. So are you given much in your training on Bruxism? Not much. Okay. All right, so fortunately, things changed. It probably started around about 2004, and there were a couple of key researchers. There was Gilles Levine from Canada, who's a dentist, and there was a sleep respiratory physiologist in Japan called Kato, and we also have a wonderful man in Australia, Peter Sestouli, and he's a respiratory physician should I say, in Sydney. And these people started to butt their heads together, and they thought, you know, really there's got to be a little bit more to it than this. And the biggest problem they were doing is they were looking at the research and they were looking at the articles, and the problem with it was just so hard to compare apples with apples. And they really boiled it down to the fact that there wasn't any standardised research protocols. You know, how do we classify a grinder? How do we classify a clencher? So these guys said, well, let's bugger it, let's set up some brick ends, and we will then have some fixed yardsticks that we can measure against, and we will reassess this as we go through our studies. So they basically, after a lot of effort, came down to these very simple classifications. And so now we know what a clonic grinder is, and we know what a tonic grinder is. So the tonic grinders are your clenchers, and your clonic, your tonic bruxer is a clencher, and your tonic and your clonic bruxer is a grinder, and they quantified this. And with that, then, they were able to generate some really good papers. And this is what started to open the door. And Gilles Levine came to Perth, I think, in 2010, and he hit us over the head with all this science, and we didn't have a clue what he was talking about. It was quite unfortunate that I didn't know then what I know now. But he's a very, very smart guy. But they also timed it with the release of one of their textbook, which I'll talk about at the end of the day. So what were the key things from their research? Well, basically what they did is they identified a very specific ascending sequence of physiologic events, which was largely sympathetically driven through the autonomic system, that linked what are called sleep arousals to rhythmic masticatory muscle activity, which is normal. And all a sleep arousal is an electrical awakening from deeper planes of sleep to lighter planes of sleep, for want of a better word, like a fright and fight response. And what they realised was that this elevated arousal activity would result in elevated levels of RMMA. And then the climax would be, if you gave these guys enough arousals, they got enough rhythmic masticatory activity, lo and behold, the teeth ended up smashing together. And that's how we had bruxism. And it was so simple. So the arousal was the key to sleep bruxism. And so therefore, for once, and definitively we could say that tooth contact was the result of motor activation. It was not the cause. So that totally buried the peripheral theory. And this largely was their triangle, what I call my sympathetic triangle. And largely what you're looking at here is an arousal, where we're going from deep sleep to light sleep, and there's a lot of sympathetic override and cardiac input. The parasympathetic system shuts down. We get a climb in muscle activity from the sternocleidomastoid up to the masseter, into the genioglossus, and whammo, we brux. But it's normal activity. All that the arousal activity was doing was being amplified, and through being amplified through whatever cause, then we were bruxing more and more. And I'm watching this bloke here, he's nodding asleep, so you keep your acid on him. That bloke there, I'm watching him.
That's the size of my eyes.
Ah, that's good. I'm old school, all right, but that's all right. I've got eyes like a fly. So basically then we understand that sleep bruxism occurs in clusters, and it occurs in what we call a pseudo-cyclic fashion, and it basically in line with what we call is CAP, which is just a normal structural alternating pattern that occurs within our sleep. So it's just amplification. That's really what I want you to get out of it. But the key thing that really came out of it was through their work with watching this transition with the SCM and the masseter and the genioglossus muscles, they thought, wow, what we're trying to do here is maintain our airway. That's what we're doing. And with that, we really started to open the door. And again, this little diagram, all of this comes from their text. It's a great little book, and everyone in this room should read it. And you shouldn't read it once, you should read it 3 times, and then the 4th time you'll realise, man, I didn't understand that, and you then go back and read it again and take notes. Because it's one of those books. You just can't read this text. You've got to study it. So really all I want you to appreciate here is that sleep bruxism is linked with sympathetic dominance in our sleep. and the sympathetic dominance is the fight and flight response. Something is wrong and the body is screaming out, man, I've got to get oxygen here for whatever reason. So therefore, if we base it on the arousals, you know, what are causing the arousals? And you can think back at that first slide I gave in the first part, where they sort of categorised, we understood like it was respiratory and it was hormonal and it was drugs and it was all these things that would cause bruxism based on the central theory, but we didn't understand why now. We have the answer. So broadly speaking, they put arousals down at different levels, but it might be at a cortical level in the brain. It might be through the autonomic processing within the brain. It might just be due to a physical injury within the brain, and there can also be genetic links as well here. But largely within the cortical, which is probably most of what we see in dentists with our sleep bruxism, upper airway resistance syndrome is another thing I want you to take away in your head tonight. And it is an area that is grossly underreported because most sleep studies are home-based, not lab-based. We can only pick this up well, or technically speaking, with a lab-based sleep study. But it's upper airway resistance that's really driving the arousals as opposed to the apneas and hypopneas, which I'll come to. But we understand that little things that would feed in on this, like in my medical questionnaire, you know, I ask if they're around livestock. Well, what do you want to know if I have, you know, cows and horses? And it's because of the effect of feed and dust. It's very important. So you're providing an approach to your patients they've never had before. Nasal piercings. Are we supposed to have our noses pierced? No. But the number of young patients that I'll see, because as a GP I get to track people with time. It's much better than being a specialist. I get to see them once. How can a specialist correlate this stuff? They can't. They see a patient once and never again. They don't know whether the patient dies of a heart attack or dementia or grinds when they're 30. They wouldn't have a clue. But we do. So sometimes being a GP is good and a lot more fun than being a specialist. Nasal piercings can be a bit of a problem because you often get inflammation. And often the people who have nasal piercings, for some strange reason, have very small alar, small nasal apertures. You start to get a bit of inflammation in the nasal aperture and that will start to elevate nasal resistance very quickly. Airlines, they're connected with airlines, and why we see a lot of sleep disorder breathing in airlines, very simple. They've got to have planes that have no moisture in them so we don't get any corrosion in the electronics. Simple. But the problem with it is it dries them out like a prune. And then we get increased resistance within the airways. So this is why you've got to start to look at occupations of your patients. Why is a pilot coming in smashing their teeth around? Why is the air hostie coming in? Why is a bloke who looks after horses? I mean, honestly, I work out in the hills. The people who smash their teeth to bits the most are the people with the horses. I thought it was just because they cost a fortune to have. I'm not so sure about that anymore. Autonomic, obstructive sleep apnea, from my understanding, kicks in a little bit through the automatic pathways, as can smoking. And neurological, that's just common sense. Obviously, we get brain injury, a lot of these patients. Post-traumatic stress disorder is another big one. You need to have this in your medical history. And there is a medical history on your table in front. And I gave a lecture a year ago down in Bunbury. I mean, half the people were asleep within half an hour, and when I left, they had made paper planes out of my medical histories. But that's their problem. They lost out. But you need to look at that. That is my medical history. There is a traditional medical history. 1 page. And it says bugger all. So post-traumatic stress, all of these things are in it. The key thing to understand